I think we'll move on then, Dr. Nikesh.
Yes.
So next, I'd like to invite Dr. Nafisa Batta, who's head of radiology in Sports Injury Center, Southern Hospital. And she's a very well-renowned MSK radiologist in Delhi. She has done fellowship in trauma and MSK imaging from Philadelphia and Melbourne, and has been, we've had the privilege of having her as a faculty in IFSCon in 2019 in Delhi. So Dr. Nafisa, very privileged to have you here, and I'd like to invite you to start your talk. Thanks.
Dr. Nafisa, you have to unmute yourself.
All right, thank you very much. Thank you, IFAS, for inviting me. My talk is on the role of MRI in ankle and foot. Well, MR is really a one-stop destination when it comes to imaging of the ankle and foot. Most pathologies you'll be able to see excellent on MR. What it gives you is good visualization of the bone, of alignment, even though it's not stress-bearing. It's good for marrow, ligament, tendon, you name it. Almost everything can be seen on an MR, and that's why it is so popular when it comes to the second imaging in ankle and foot. It's great for occult fractures, which would be missed on an X-ray as well as a CT. And it's good for periosteal avulsions as well. And we'll see a few examples of that. It helps to characterize soft tissue lesions also. There are, however, some challenges with the use of MRI. Of course, there's a lot of complex anatomy in a little region, and you need high spatial resolution images. So a good strength magnet is required. There's good planning required. The good protocols have to be set by the radiologist and the technician. The technician has to acquire images in a certain way, otherwise the anatomy starts to look really warped and abnormal. And what's there to understand here is that the ankle and hindfoot is acquired in one protocol, which we call ankle, and the mid and forefoot is in the foot protocol, right? So this is how you should even try and request for MR. So it's not, ankle and foot is not just, the whole thing is not one MRI. There are various sequences for the ankle and foot, but we'll see that a bit later. And I want to show you that how to look at the anatomy when scrolling through a stack of images. We'll look at a few pitfalls. As Aditya mentioned, susceptibility artifacts from orthopedic hardware limits the resolution on MRI, and that's where CT would be beneficial. There's a magic angle artifact that the tendon may look a bit edematous, or it could even potentially look torn if the tendon is at the acquisition plane of 55 degrees. And of course, if it's not planned well, there will be difficulty in looking at the MR. And of course, any other artifact like motion artifacts or any other contraindications to MR that the patient may have, maybe claustrophobic, may have had some pacemaker, etc. And that's something to be careful about. And when we look at the MR, everyone has a certain checklist. You could either go inside out, you could see bones first, and then you could look at ligaments and then tendons, or you could have a quadrant sort of an approach, but that is really an individual's prerogative. So we'll just look at how this is done, and I'll show you. I can share my screen here. So this is how the first three sagittal images, I like to look at them. One will be a T1, in which case a fat is bright, it's not suppressed. The other one will be a suppressed image where the fat is dark. The cortical outlines are always dark. And then in the T1, the fluid will be dark, whereas in any kind of a T2 weighted image or a stir weighted image, even if you suppress the fat, the water becomes bright, and that is why you look at these images to look at hot spots. So anytime you have edema or fluid, you can start to look in that region for pathology. And this is a case, just a random MR. We'll start from the medial to the lateral side.
Sorry, Dr. Nafisa, I don't think we can see your imaging there. We can just see your PowerPoint slide and not your
Oh, I
imaging.
see. I see. Okay, let me just do that again. Can you see that now?
Yes, that's right. Yeah,
All right.
thanks.
So these are the three images. That's the T1. This is the fat saturated sequence. And this is a GRE. So GRE has excellent resolution for the cortex, the bone, the trabecular pattern, and the cartilage. Right? So small avulsion fractures would be better seen on GRE. We'd also be able to look for hemosiderin on GRE. But mainly the workhorse of ankle would be a fat saturated image. So this is how we like to look at them. And I'm going to just scroll through. So we'll go from medial, that's the medial side. We look at the medial malleolus, the colliculi where the deltoid attach. You start to look at the medial aspect of the talus and the calcaneum, the sustentaculum tigli, and the middle facet of the subtalar joint. And as we go a little more to the center, you start to see the plantar fascia very well. You look at the Achilles tendon. This is something that you can possibly best image only on the sagittal. We go a little more central, you start to see the sternal process, possibly an osteotrigonum. You can look for posterior and anterior ankle impingements here. The sinus tarsi starts to open up as you go laterally. You want to, again, always look at these joints, the cartilage, for reasons of degeneration, and that could be a cause of patients' untraceable pain at times. So as we go forward, we start to look at the contents of the sinus tarsi. Again, you're looking at the talonavicular joint as well. You can go more laterally. We're going to see the talocalcaneal ligament and some contents here. We see the cervical ligament and then the slips of the extensor retinaculum going in there. We see the calcaneo-cuboid articulation. You could look for stress fractures in this region. So this is something that we like to see as well. And then you go back to the lateral malleolus on the far lateral side. So this is how we would look at the sagittal images. Then the next thing to look at would be, again, the axial images, in which we have one of the sequences will show the fat as bright and one of the sequences will show the fat as dark, right? So that's the coronal, just to show how this is planned. Sorry. Right. And that's the coronal PD image. So this is somewhere in the center of the ankle. And we look at how the scan is planned. It's going to be parallel to the tibiotalar articulation in the coronal plane. We start from top to bottom. So that's the distal tibia and the fibula going down. We start to see the tendons. So you can look at medial tendons, tibialis posterior, flexor digitorum, flexor hallucis, Achilles, and that's the plantaris, the peroneal tendons there, and the extensor tendons as well, tibialis anterior, extensor hallucis, and digitorum. As we go down further, somewhere around the line of the joint, we'll start to see the syndesmotic ligaments. And we like to look at both these simultaneously. That's the posterior syndesmotic ligament. This would be the anterior syndesmotic ligament. And there is an interosseous component which is a little superior. So going down again, this is the talus, medial malleolus, lateral malleolus. Further down from the syndesmotic ligaments, as we go down, we're going to now see the talofibular ligaments. So that's the anterior talofibular ligament. And that is the posterior talofibular ligament. You want to see for a dark signal, that's normal. The posterior looks always a bit thicker because it has this fibrofatty insinuations, but this is normal. This appearance, this gray appearance is not a tear. One is always looking at the anterior talofibular ligament to look for a potential tear in a case of a twist injury. That is the talus, where it starts to look very egg-like. You see the medial tendons traversing. This is the intramalleolar course of the lateral and the medial tendons. And then you look like at the talonavicular joint, you get a good sense of what is happening here in the midfoot as well. And you could even look at the Lisfranc's ligament in the far anterior scan. So this is how we look at most of the pathologies. One thing to add here is the calcaneonavicular ligament. The calcaneofibular ligament. Look at this dark structure here. This is the calcaneofibular ligament. It can be very difficult to look at. And this structure, as we go up, will attach to the fibula. And just looking at it itself, we can see this dark band, then that's normal. It forms the floor of the peroneum. So this is where to look for that. We also do something like a coronal oblique to sometimes better see the calcaneofibular ligament. So in this case, these are the peroneal muscles, peroneal tendons. And we're going to look at this, how the scan is planned. This scan is planned 90 degrees to the inframalleolar genu of the peroneal tendons. And we get a good sense of what's happening in this region. At times, it can be difficult to see the calcaneofibular ligament, but in this case, you can see it nicely. And this is the reason why we at times do this. This is not standard protocol. Just take you back to my presentation, and I hope you can see that.
Yes, we can. Yeah.
Okay. All right. So just going back now to a few cases. As I said, it's a one-stop shop. There's lots you can see on the MR, and we'll look at a few cases. This is a T1 sagittal. That's a fracture through the stida process. This is a cause of pain for the patient. This was a case where patient had massive edema and there's a fracture through the talus which is undisplaced. And if you look at the X-ray, it's pretty innocuous. One would completely miss this injury, and the MRI just lights up the talus. This is another case, 26-year-old runner. We looked at the X-ray and we could see that there was a complete C, and that's a talocalcaneal coalition. But then again, if something were to be planned for this patient, any kind of a surgical approach, you would need an MR, or you could even go in for a CT in such a case to look at the coalition. Is it fibrous? Is it osseous? Is it cartilaginous? Is it fibroosseous? So that's, you get a good sense of what is happening. Apart from, so this is the large talocalcaneal coalition in this case. Apart from that, you also want to look at the other tendons, and such patients are prone to have a flat foot later on. So this is a case who had more or less a pes planus, and apart from the stida process that was prominent, we can see that the C is disrupted, so there's no talocalcaneal coalition. But then in a young patient, whenever we look at anterior talar beaking, it kind of sets our search for what is happening, because most likely we are missing a coalition. In this case, we weren't too sure, but the MR easily shows us the the calcaneonavicular coalition. In this case, you can see that facet there. So this was a fibrous coalition, a calcaneonavicular coalition. This patient, apart from the coalition, also had pain on the lateral side. You'll see that there are some areas of stress edema. This patient has a flattish arch, and there's a bit of free fluid around the plantar fascia. As we looked at the axial imaging, we can see that the peroneal tendons were abnormal. They had high signal. The peroneus brevis is thickened, it's tendinotic, and it is developing a longitudinal split tear at its inframalleolar course. So there's additional information that the MR is giving you in this case. This is a patient who came back from boot camp training and had lateral sided pain at the hind and midfoot. And the X-ray again didn't reveal much, even on retrospect. And the MR is, of course, very easy to see that there was a occult stress fracture of the cuboid in this case, something that happens quite commonly. This is another case, went around with pain for a long time. It was training for something, I can't remember. But you see that there's edema here, and that's a very small, incomplete sort of a fracture line, well seen on the T1, and this was a calcaneal stress fracture. Ligamentous injuries, the most common thing, the most common requisition why we do an MR is to look at the ATFL. That's the most commonly torn ligament. And so this is a footballer. We always want to look at the syndesmotic ligaments to see if they are intact, and they were. In this case, you have a mid-course tear, a full thickness tear of the ATFL. Now, ATFLs can be torn either from their talar attachments or from the fibular Flagstaff tubercle attachment, or it could be a small bony avulsion from any of these areas, or it could be a mid-course. And we always want to tell the surgeon exactly how the tear is, what is the thickness of the tear, what is the edema in that region, whether this patient will be put to conservative or not is the surgeon's call. Most patients do well with conservative treatment. And when we have an ATFL tear, we also want to look at a CFL tear in that case. So this is a patient here, again, an axial PDFS. We look at the syndesmotic ligaments, which are normal. This is the lateral malleolus, that is the talus, and that is the medial malleolus. So as we go down here, we look at this thickening of the superior fibers of the ATFL. You look at the ATFL, it looks abnormal. It's too gray. It doesn't have a nice dark taut signal. So we can confidently say that there's a partial tear of the ATFL. Few of the fibers inferiorly were intact. So this patient again went for conservative treatment. And when we look at such a patient, we always want to look at the CFL. Now, CFL does not tear by itself. There has to be an ATFL tear with it. And the fact that we see a dark CFL attaching to the calcaneum is reassuring. There is some edema around the calcaneofibular ligament. I'll give you that. It's thickened, but it's more or less intact. This is a patient who had repeated injuries, and look at the ATFL. It starts to remodel, and there's at times there's hypertrophic scarring of the ATFL, which is abnormal. There can be a very attenuated ATFL that too is abnormal. This is a case where a wrestler, and if you see on the lateral side, this is the CFL, which is so thick, it's almost as thick as the peroneal tendon. So these are the peroneal tendons, and this is the CFL. I'm sorry, we have grainy images here because the patient was in pain. That is the CFL again, now starting to look a little more gray and abnormal. And then you see that it's completely torn, and there's this big stump, rolled up, bunched CFL, and it does not attach to the calcaneal insertion. There's a bit of reactive osteitis at the calcaneum as well. So this was a full thickness rib of the CFL from the calcaneum. This patient, even though looked like she had a dark ATFL which seemed intact, well, it wasn't. There was a high grade tear from the fibular attachment. This turned out to be a complete tear intra-op. This is an interesting case, and it demonstrates the beauty of MR. And even though this patient had a lateral sided soft tissue injury, and we were expecting to see lateral ligament tear, but if you'll focus yourself on the medial side in this case, what we're seeing is that there's impaction marrow contusions at the distal tibia, at the medial malleolus and the medial margin of the talus. And apart from that, what we're looking at is that there's edema within the deep fibers of the deltoid, but we're looking at this abnormality. This is stripping of the periosteum. So this is medial facial sleeve stripping. And this can be a cause of chronic instability in patients and should be recognized, because if you go to repair the lateral side and patient comes back with instability and you find out that this had completely stripped and that was not addressed, it doesn't look good on anyone. So this is actually medial facial sleeve injury. And we see these commonly, and the more we see these nowadays, we're able to grade them and provide that to the surgeon. And this is how it will look on an axial. It'll be like an entire curvilinear cortical extra line, and that's abnormal. So you see that this is completely stripped. So it takes away the flexor retinaculum from the bone, and it can go all the way, taking away the extensor retinaculum as well, and the superficial deltoid ligament attachment to the medial malleolus. So the entire thing falls loose from the bone, and it's an important entity to recognize and address. This patient also had lateral-sided ATFL, high-grade partial tear, and the CFL was intact. So this is what facial sleeve injuries look like. You could have them just ripping from the medial malleolus anteriorly, or you could have them ripping completely, disjointing the entire apparatus from the bone. Tendon pathologies, I think all of you know Achilles tendon, even though you can see this amazing on ultrasound, and I think for most cases, I would prefer an ultrasound. But in such a case, you could tell the surgeon where the tear is. Is it just interstitial? Is it complex? Is it oblique? Is it transverse? Is it just tendinosis, etc., etc. This is a patient, she is a long jump enthusiast, actually a hurdler, and had a disruption of the plantar fascia. This was traumatic, and this is how we see it beautifully on an MR. You can see the edema around it. You can see the marrow contusion here and the thickening of the plantar fascia. This was the central, the thickest cord of the plantar fascia that was affected. The lateral cord was normal. Something again commonly seen, this is a 48-year-old female with foot pain. You see the pes planus right away on weight-bearing x-rays. There's a large spur there, so you know that there's going to be a plantar fasciitis on the MR. But why we do an MR in this case is to, of course, we get a sense of heel valgus here right away, but then we also wanted to see the posterior tibial tendon. This patient had medial-sided pain, and the single heel raising test was positive. And this tendon looks abnormal as it attaches to its navicular tuberosity, and this is tendinosis. So this is PTTD. This is posterior tibialis tendon dysfunction. This is a patient who had intractable pain, plantar aspect of the foot. The X-ray was normal. The MR was done at a time of pain for this patient. You see edema at the peroneal tendons right away. You also see some edema in the medial side. Now, this is something that happens interestingly at the master knot of Henry, where the FDL and the FHL cross over. This is a patient who had intersection syndrome, and a ganglion cyst had formed because of the repeated friction rub. And we were able to diagnose this super easy on the MR. So of course, impingements can be looked at at MR as well. And you also want to plan a CT if you're going in for a surgical approach. But for most cases, MR will pick up impingement. And in such a case, this is a patient who had these small spurs, early signs of impingement. The patient had pain in this region. At the time of acute pain, you'll be able to pick up capsular edema, marrow edema. Whereas when patients are pain-free, these signs would not be seen. You could even pick up capsular thickening and scarring as well. And this is a case where if you rely too much on just one modality, this patient had pain, but we didn't see a spur in this region. There was capsular edema. There was no stress fracture. After 3 months, it looked the same. And then if you do a CT for this case, there was an osteoid osteoma. So at times you need 2 modalities to make the diagnosis. Some pathologies of the forefoot.
So 2 more minutes, Dr. Nafisa.
All right. So this is a patient who had plantar-sided pain at the first metatarsophalangeal joint. And right away, we see that the sesamoid is missing. And even though we can see that well on the X-ray, we want to know what the status of soft tissue is. And that is why we went in for an MR. There was complete absence of the tibial sesamoid. And we also see a small tear of the medial head of the flexor digitorum, flexor hallucis, sorry. And that's the glenosesamoid apparatus. You're going to see the same in the axial plane. You see the plantar plate was intact, the lateral sesamoid was okay, and you see this kind of soft tissue edema. And in this case, we also did an X-ray for the patient. And this was a bilateral condition wherein the patient had complete absence of the tibial sesamoid. On the right foot and on the left, there was a small sesamoid. A marathon runner with pain, forefoot pain, the X-ray shows the flattening well, the MR confirms the avascular necrosis. And I want to show you one case where MR was a problem-solving tool. This is a 14-year-old badminton player and a friend, a surgeon's son. So this was thought to be a stress fracture, and he came back after a few months, and we thought it would be a good idea to get an MR done again. Because this was not a familiar site for stress fractures. We would like to see them somewhere here. And then he was a badminton player. There was no history of running. When we did the MR, we did see the edema for sure. But apart from that, we're seeing that there is some pathology here. There is actually a benign tumor sitting at the base of the second metatarsal. And the edema is because he has a pathological fracture through it. And there's a sharp zone of transition which points towards the fact that this is a benign condition. And there's a high signal homogeneous through it, which shows that this is a chondroid lesion. And we gave the possibility of either a chondromyxoid fibroma or a fibrous dysplasia. And the patient was on follow-up, and that's enough to reassure, because most of these lesions can also resolve by themselves. So we just leave it to that. Thank you very much. These are Japanese sandals, by the way. They're called waraji. They are made from rice straw. This is one of the pictures I took on a recent trip. I'm not taking any trips. I don't know when I'm going to take the next one. So thank you very much, everyone. I'll take some questions if there are any.
Yeah.
Thank you, Dr. Nafisa. I think that was great, interesting cases, and really learned a lot today from all the lectures, really. So, Dr. Nikesh, and I just want to mention that we have Dr. Shakir, who's the president of Indian Foot and Ankle Society, with us, and also Dr. Rajesh Simon. So, if you would like to add in the discussion, please, we would definitely want you to. So, Dr. Nikesh.
We have a few questions from delegates. Yeah. Dr. Nafisa, can you just tell us what is the normal ATFL thickness on MRI? I mean, how do we assess whether it is scarred, hypertrophied, or attenuated?
So I don't go by a measurement. I don't usually see that. That isn't really important. We have well-built patients in which the ATFL could be 4 to 5 mm, and I'd say it's normal. And I would have a more delicate built patient where the ATFL is, say, 3 mm, even that is normal. But most of the times, an ATFL would be on an average of about 4 mm or so. And most important is to see that it is a parallel thick band. There's no undersurface irregularity. There's no over the surface irregularity. There's no heterogeneity in it. There's no focal thickening in it. So these are the signs that would tell us that the ATFL is healthy or it is abnormal, or did the patient have scar remodeling earlier? And most patients who come to us, I think, not even if you're not playing a sport, sometime or the other you would have twisted your ankle in your life. So it's really difficult to say that a patient would have an absolutely normal ATFL when he got an ankle MRI done.
And for correlation, do you suggest to combine CT and MRI both studies, or only MR would be sufficient to get all the information?
I think definitely both. So I think getting an MR is where if you can make the diagnosis easily on X-ray, then that's fine. But if the patient is in pain, you want to get an MRI done. So you want to confirm the correlation, and you can also look for other causes of patient's pain. The correlation may actually be painless, and there could be something else that is hurtful to the patient. So you want to get the MRI done for sure. And to plan further, you would need a CT. I think that's essential. It's one of those cases where you should do both of these modalities.
Yeah, and in foot and ankle, we have many tendons who curve behind the bone. So many times the tendon is obscured by the bone. So how to assess the peroneal tears, which is behind the lateral malleolus, or the tibialis posterior, which is behind the medial malleolus, and curving? So how do we assess that? And do we have any complementary sonography? Should we go for any complementary sonography along with the MR to know the tendon status, where it is curving behind the bones?
Right. So there are two parts to this question. One is that with the kind of MRI images that we acquire today, most cases you'd be able to look at the pathology right away in spite of their course, because we have a high spatial resolution imaging. Then, of course, we look at MR in all 3 dimensions, and I showed you a coronal oblique where I'd be able to see the peroneal tendons better. So those are some problem-solving mechanisms in which you could potentially see things well. Having said that, ultrasound, since this is a superficial structure, ultrasound is excellent when it comes to looking at tendons that are looping around the malleoli. Actually, ultrasound is excellent whenever you're looking at a superficial pathology, because you have very high resolution images that are acquired in the linear transducers. And you'd be able to see, grade, follow up the patient, do ultrasound guided injections, and so on and so forth. So it, of course, has this kind of application. But first time, I would request you to possibly do an MR for the patient, find out where the pain is, know that there is nothing else, and then follow up the patient on ultrasound.
Yeah. Dr. Shantanu has a question. Dr. Shantanu, please.
Yeah, thank you, sir. Thank you for that excellent presentation.
Shantanu, can you please speak louder?
Yeah, can I hear me now?
Yeah, sure.
Oh, wonderful. First of all, thanks a lot for that wonderful presentation. MRI does have a very important role, as I understand, in cases of lateral ligament instability of ankle. Am I right?
Right.
Yes. So recently I had a patient who was operated by me. Brostrum's repair was done with suture anchors, and he had a repeat fall, and he started showing some symptoms of lateral instability again. On clinical examination, it was like 50-50. It was not very sure whether he has sustained the same kind of tear or not. We got an MRI done, but the result was not very clear. We got a report that yes, the repair is intact. So how much can I rely on that report? That's a very pointed and blunt question.
Okay. So again, you have to be working with that radiologist, and you have to be familiar with those images to say for sure that I have full faith in this report. How the MR is acquired, the plane of acquisition, the strength of the magnet, everything adds quality to the MR. Then, of course, is the interpretation of the radiologist. If you would have done an ultrasound for this condition, you'd be able to see the ATFL, the CFL very well. There'd be no susceptibility artifacts from the Bostroms, even though there's only a very little artifact, and nowadays we have sequences to reduce that itself. So I think in such a case, in a post-op case, the quicker way, a better way of doing things would be ultrasound. But having said that, even ultrasound is very operator dependent. I mean, you have to be sending that patient to somebody who's doing ATFLs and CFLs every day, seeing them on ultrasound. So I think this is about choosing the radiologist and choosing the modality depending on what you have around you.
Right. Thank
So,
you so much.
Raghav, your comments on that, Dr. Raghav? Do you want to comment on?
I think what Nafisa has said she said well. One more point is that a lot of MR has been done on teleradiology, and the history is very limited. And as it is with the radiologist, so, even with the orthopedic, if you have a good radiology report, you need a good orthopedic to treat it also. But, the MR, actually what I feel personally, the man behind or the lady behind the machine is very important. It's a team. The technician is very important in that, and the radiologist is probably more important, because what Nafisa you'll be getting, because you are sitting behind the machine and doing it. So many radiologists who are, just sitting across the continent and reporting. I think the MSK reports will be a difficult task. What Dr. Daftari also, I think, agree with me.
Yeah.
Actually, sorry. So my point on this is that if you have continuous ligament, that's a very good sign. I would not disagree with that entirely. So on MR, one of the things you can do is you can tell ligamentous continuity, but you cannot tell ligamentous laxity. So you will oftentimes see structures that look continuous, but clinically you will have laxity. And the classic example is something like the PCL in the knee. You can have a PCL tear that remodels very nicely, and so you see continuous PCL tissue. So as far as on MR, I will read it as continuous PCL, but you will see a posterior sag. Similarly, with the ankle, we have plenty of patients who have repeated ankle sprains, but they have repeated stressed injuries of the ankle ligaments. So the ankle ligaments look continuous on the MR, but there is clinical laxity. So in answer to your question, I would say that that patient could have a continuous ligament, could have laxity associated with. Now, clinically, you have to take the call as to whether you need to go back and restabilize that, or you're happy with it and you would say that I'd rather go on along the course of saying, let's go back to ankle stability work by physio and see how you respond, and then decide on whether we want to reconstruct that ligament.
There is a question from Dr. Rajesh Simon to Dr. Nafisa. 3 Tesla MRI is preferred, or 1.5 Tesla MRI should do for foot and ankle?
I think 1.5T is good enough. Now, the images that I've shown you are all on 1.5T. As long as you have a special dedicated ankle coil, you can get good images. Of course, 3T is better. There is no doubt about it. If you were to compare one to the other, this would look better. But then I don't think you would miss a pathology just because you did it on a 1.5T. If you have a specialized ankle coil, you can acquire good images. And if you can read the MR well, it's all the same.
Dr. Mahendra wants to have a question.
Yeah, hi. It's a great presentation. I think there is a term in radiology, it's called as satisfaction of search. So I think sometimes we just give up doing one investigation, think that everything is normal. And what Nafisa has really put up is that you can't stop till you have really nailed it. If a CT is ordered, you don't find anything, go for an MRI. I think using both these investigations judiciously, and of course, as you said, ultrasound is operator dependent. And the question about which radiologist to refer, I think we need to train our radiologists along with us. I think we should sometimes go and visit them along with the patients and do a teamwork so that, they also try and understand what is the clinical. So most of the time, the radiologists do not have the clinical background of what's happening with the patient. And we need to be very, very communicative and do it as a teamwork. Excellent presentation, Nafisa.
Right. And one thing I would like to add here is that when we have patients who are active, who are playing around the field, today they're coming, if you as an orthopedic surgeon tell us, okay, this medial sided pain that we are worried about, and the patient would have probably had a scarring in the ATFL, but right now he's come with medial sided pain. So I'm going to try and find what the pathology there is. So the patient's condition or the patient's site of pain also actually guides us to where the diagnosis is important and what to miss, because a lot of these patients have pathologies going on in their ankle, but that is not the cause of his pain today. And that is something that we would put in the ancillary findings.
Yeah, there is a question from delegate Dr. Dayanidhi Desai. He is a senior orthopedic surgeon from Surat, and he is asking, in tarsal coalition, what is the preferred investigation, MRI or CT scan?
So you make the diagnosis on X-ray. If you can't make it on X-ray, you go in for an MR because you want to look at everything once. And then if you're going in for any kind of surgical approach, then you want to go for a CT. CT actually there are various CTs that classify the kind of coalition. So you even in calcaneal coalitions, there are 4 or 5 types of coalitions, and you'd know exactly what to go, how much to chop, what not to do. So I think CT is required. It is an adjunct. You have to do it when it comes to coalition. But first time you would do an MR after an X-ray.
I think, Maninder, we should go ahead.
Yes,